learn something new about burn care, especially in the pre-hospital setting. So tonight, these are the sources that I've used for my presentation. I have given this presentation a few times, and not much has really changed in the way of burn care. So mostly everything tonight has been up to date. And we'll move on to some objectives tonight. Tonight's presentation, I would like to kind of review some of the topics of burn care, kind of going through the different body systems involved in burns, primarily really focusing on the skin and airway involvement in burns, and also identify the different types of burns, and ultimately the proper treatment of the burns that we're going to talk about tonight. So I guess we'll just kind of really jump in right away. The big thing that we talk about in burns is obviously the skin. Now, the skin is the biggest organ in our body. And when we talk about the skin, we break it down into three different levels of the skin. So the first one is obviously our epidermis, as we see in the presentation. And this is our main line of defense. The skin helps us protect us from the sun, the heat, the cold, infections, bacteria. So this is the most important part of the skin. The next is the middle layer, and that is what we call the dermis. Now, as some of us can see, the dermis is the middle portion of the skin, where we kind of begin to develop the skin glands, some vasculature, and as we can see here, also hair follicles. And finally, the innermost layer is our hypodermis. And as we can see in the picture, this also is where we have more continuation of vasculature, as well as some fat tissues as well. So now that we've kind of covered the skin, we'll kind of start to begin our discussion on airway and the respiratory system involving burn care. There's three different types of inhalation injuries, and those are exposure to toxic gases, which include carbon monoxide and cyanide, which we will discuss a little bit later. And I'm also going to briefly touch on supraglottic injury and injury to the subglottic levels of the airway. Next will be, we'll kind of dig right into some carbon monoxide poisoning. So ultimately with carbon monoxide poisoning, basically what happens is your body becomes asphyxiated from oxygen. And that's because carboxyhemoglobin levels with carboxyhemoglobin levels, we start to see some damage anywhere from 50 to 70%. And kind of the science behind carbon monoxide poisoning is ultimately the carbon monoxide molecule binds to the hemoglobin. And ultimately that begins to cause issues with our cells, and ultimately leading into damage to our organs. Some of the main signs and symptoms that we see with carbon monoxide poisoning are going to be shortness of breath and headache. Those are going to be your major ones that we see right out of the chute when we take care of our patients. And also, later on down the road, once the CO continues to build up in the body, we'll begin to see some nausea and vomiting, and as well as dizziness. And this is ultimately because the body is starting to become hypoxic and starving for oxygen. And when we talk about carbon monoxide poisoning, there's obviously some important treatments, and those include obviously high flow oxygen, monitoring the patient's vital signs, cardiac rhythms, but the ultimate treatment for it is going to a hyperbaric chamber. There are a few of them located in our area where I am. However, it's good to know maybe after this treatment, after this presentation, where your hyperbaric chambers are located here in the state. Next, we'll talk about cyanide poisoning. So cyanide poisoning, this is really starting to become a hot topic. And we're seeing this a lot primarily because of the way that things are being made these days. So cyanide poisoning ultimately is just a product of incomplete combustion. And ultimately, it's can also lead into combustion of synthetic products. And we're seeing this a lot in house fires and the way that things are being made these days, which we'll kind of discuss later on. And ultimately, as far as a pre-hospital setting, it's very difficult for us to diagnose. And primarily because when we talk more, you'll be able to see that there's not a lot of differences between the carbon monoxide versus the cyanide exposure as far as signs and symptoms, and ultimately the science behind the cyanide exposure as well. So like I said before, cyanide is a product of combustion. It's released by many materials with high temps and low oxygen. So when we think about this, we think primarily house fires or fires that we go to that a patient may be burned. So, and it's because the way that products are being made these days. So couches, mattresses, shades, window treatments, and also really breaking it down to is what houses are actually being made out of these days with the fiber insulation, the particle boards, the OSB boards, the way that things are being made. They're starting to see that these, once they start to begin to burn, the off gas of cyanide is present. So ultimately, kind of with CO, cyanide is a silent attack. Ultimately, it's attacking the red blood cells, so the body's unable to use oxygen. So when we break this down further, the pathophysiological way, ultimately, the cells are not using oxygen, which is ultimately causing anaerobic metabolism. And due to that anaerobic metabolism, there's going to be a start of increased buildup of lactic acid, which is going to cause metabolic acidosis. In return, it's ultimately going to be killing our tissues because of the lack of oxygen. So as we can see with carbon monoxide as well as cyanide, that there are some very similarities between the two. So ultimately, we've talked about treating carbon monoxide, and that's a pretty basic and general treatment. But as far as treating cyanide exposure, they are starting to come up with new and great technologies and medications. And the one that has really started to hit the market is cyanokit. And ultimately, with the cyanokit, what it does is that it breaks down the cyanide cells. So in return, you're creating a non-toxic cyanocobalamin, which allows O2 to be used again in the body. And what's nice about these cyanokits is that in the pre-hospital setting, if you're having a difficult time differentiating between, is it cyanide exposure, is it carbon monoxide exposure, this cyanokit is not going to hurt them. Worst case scenario, it just gets excreted from the body. Downsides with these cyanokits is they are extremely expensive. So obviously, be very cautious when you're giving these as far as a financial aspect, as because they are extremely expensive. So like I said before, we've kind of really dove into the carbon monoxide exposures and the cyanide exposures because those are two of the biggest exposures that we're going to see. We're going to be responding to a burn patient. Now, like I said, we're going to kind of briefly touch on inhalation injuries above and below the glottis. So ultimately, inhalation injury above the glottis. We're going to see these a lot in thermal burns. Um, it's going to be thermal injury to the respiratory tract above the glottis. And ultimately, it's because of the heat exchange that has happened. And ultimately, because of the heat exchange, you're going to be having issues to the area above the true vocal cords. So ultimately, later on, we're going to talk about airway, and we're really going to hit on airway. And I guess we're just going to start right now. With a burn patient, it is so imperative that you assess the airway right away, because that's ultimately going to hopefully provide a better outcome to your patient if you are very aggressive with your airway when you first get to your burn patient. And then obviously inhalation injury below the glottis. So when we talk about these can also be thermal or chemical. These are the main two that we see with the injury below the glottis. And ultimately, with the thermal and chemical, going more on the chemical side, we're talking more about off gases in either house fires or chemical exposures that are causing the damage to the epithelium of the large airways. Excuse me. So like continuing on with this, ultimately with injuries below the glottis, these are going to be more severe. And some of the changes that happen is that the epithelial lining begins to slough off of the airway. And this is because of the heat that's been exposed and as well as the chemicals that have been exposed that are going to cause this. And ultimately, which is going to lead to inflammation of the airway. So that's why I said, and while I'll hit on it probably 100 more times during the presentation, airway, airway, airway. The sooner you can get a patent airway, the better, because ultimately in the long run, the inflammation is going to be causing edema to the airway, as well as pulmonary edema, and ultimately can cause bronchial spasms. So we have to be very aggressive with our airway in our burn patient. All right, so now that we've kind of hopefully reviewed a little and maybe have learn something new about the airway, we're going to begin to talk about the degrees of burns. So now that we've kind of touched on the skin, we've kind of understand that there's 3 layers, and each layer kind of will define, the type of, the degree of burn. So we break these down, burns, into 3 separate degrees. We have first degree, second degree, and third degree. Now, first and third, those are pretty straightforward, that you're going to be able to tell, yes, that is a first degree burn, and yes, that is a third degree burn. But with second degree burns, we kind of begin to classify them in 2 different types. And we'll talk a little bit more on that when we get to that point on the second degree burn. So I kind of touched on this already, but you're going to, the main important is that we want to be able to calculate the severity of the burn, because that's ultimately in the long run going to help with our treatment of either fluids or where we're going to go with our patient in definitive care. So some of the things that we want to do when we're maybe going to the scene or at the scene, kind of a little toolbox toolbox of ideas and tools that we want to use, and kind of thinking about what was the temperature of the agent that is causing the burn. Was it boiling water? Was it flames? Obviously house fires are hot. We all know that, but maybe trying to figure out, okay, how hot was it? And also the chemicals that are being used. Some chemicals are at boiling temperatures. People work with chemicals on a daily basis. Some of them are boiling. Accidents happen. So we need to be able to understand or try to figure out, what the actual temperature of the offending agent was. And next, what is the duration of the contact? Was it 5 minutes? Were they in a car fire and the fire department had to come and take them out, and they were in the car for 10 minutes? Was it a simple chemical that was on them, and they were able to get it off, but yet there's still a burn. These are kind of things that are very important. And then also the thickness of the epidermis and the dermis. Obviously, we deal with all different walks of life in the pre-hospital setting. We can go from a very muscular individual to a little old lady with very thin skin that if she is to have a scratch, she could cause a skin tear and cause bleeding. So we need to, while looking at our patient, kind of try to figure out the thickness of their epidermis and dermis. Because obviously, the thicker the epidermis and the dermis, possibly the better outcome. It could be that they could be exposed longer or to a agent that ultimately could kind of make the degree of the burn. And then finally, the blood supply to the area. The patient could have an underlying medical history of problems with their arteries, atherosclerosis. There could be so many contributing factors to the blood supply of the area. So those are some of the things that you might want to keep in your toolbox while going to these calls, and even on scene, trying to figure these things out. Because ultimately, the more information that we can get is ultimately going to be better for the patient in the long run. So now that we've kind of talked about that, now we can start to classify the different degrees of burns. So obviously the first degree burns. Probably the majority of us have probably had a first degree burn at some point in our lives. The first degree burns only involve the epidermis. This ultimately is caused by a flash, possibly a hot liquid, or the sun. Obviously, the picture shown is a sunburn. We all at some point have probably gotten a sunburn before. The big thing with first degree burns is that most of the time there's not going to be any blisters. There's no blistering effect. It's going to be very painful, red, and irritated. And after a few days, it's going to go away. And you hopefully during that time you don't have any friends that come up and slap you in your back with your first degree burn, because it's going to be painful. It's going to hurt. And like I've said before, we've probably all been there at some point. So with the second degree burns, like I've said, there's two different kinds. And the first one is partial thickness burn. And this is when it's going to involve the epidermis and portions of the dermis. So obviously with first, second, and third, the bigger the number gets, the more severe the burn that we're dealing with. And also, this is when we begin to see more of a chemical substance component. There's going to be fire, there's going to be hot liquids and chemical substances that are the most likely cause this burn. So we do type 1 and type 2 with the second degree burns. And with the type 1, it's thin-walled blisters. This is going to be the differentiation between type 1 and type 2. It's going to be the blisters. With second degree type 1, the skin is going to remain pink and moist. And we have to remember that the skin is going to be soft and tender to the touch. And ultimately, because the top epidermis has kind of been sloughed off. So that's what's causing that skin to be pink and moist. That's what's causing those blisters. So for those of you that are able to see the picture, we can kind of begin to see some blistering, but it's very difficult to see because they're so thin. So obviously moving into second degree type 2, it's going to be more severe. These blisters are going to be more profound. The skin is going to be red, it's going to be blanched, and it's going to be white. There's been some serious irritation to that site. So obviously, the patient is still going to be able to feel some pressure, but the pain is going to begin to go away, and that's because we're starting to burn off those pain receptors on our skin. Primarily because the deeper the burn, the more areas that we're burning. The epidermis and the dermis are going to begin to be damaged. And then ultimately, things that we're going to have to think about is that there's going to be poor capillary refill to the burn site. And this is because we're starting to, the vasculature and the pain receptors and the hair follicles and the sweat glands, those are all going to be damaged because of how deep the burn is. Now, third-degree burns, these are going to be very severe burns. We also call these full-thickness burns, and this is going to involve the epidermis, the dermis, and the hypodermis. The skin is going to become very dry, hard, and tough. It will almost look like leather, almost look like an actual piece of leather, and at times will appear white. And this is ultimately because the perfusion to that site has been damaged, and that's what's causing that white leathery appearance. And like I've said, the entrapment time is ultimately going to kind of, if there is entrapment, is ultimately going to kind of give you your severity of the burn. So usually we see these with prolonged entrapment. So obviously those that are able to see, we do have a pretty severe burn here, a third-degree burn. So as we look at the picture, we can see that the skin almost looks leathery. We kind of have some white around the edge of the burn, but it's darkened. It's a severe burn. And ultimately, those that are looking at the picture, the cut down here, that's ultimately those are done to try to actually help with the blood flow. Because with a third-degree burn and severe burns, the skin becomes hardened and contracted. So ultimately, they have to do those to relieve that pressure buildup. You also see those a lot on the chest due to chest wall movement. If they get burned in the upper portion of the body, they'll do those to actually help the patient breathe. All right, so now that we've kind of established, okay, we know that the skin's involved, we know that the airway's involved, we now kind of understand, okay, these are different degrees of burns. Now we're going to move into a critical burn. What classifies a critical burn? So ultimately, being pre-hospital providers, you're going to have to make the judgment calls as far as, okay, does this patient need to be urgently transported? Does this patient need to be transported via helicopter? Can I do ground? Will my trauma center take this patient? But some of the things that are critical right out of the chute are going to be burns to the face, the hands, the feet, the genitalia, and the perineum. And if we look at these are all very vital organs or body parts that would classify that as being critical. And also third-degree burns. Third-degree burns are very severe. They need to be treated. And electrical burns. Electrical burns are so critical, and we will kind of touch on this a little bit later, because the way I like to think of it is that when we put someone on a defibrillator, and when we're taught in school, you have to have two pads on because the electricity has to flow. The way that I like to look at it is that imagine putting one AED pad or a defibrillator pad on the person. You hit the button, the electrical shock gets sent. Well, that electrical current is going to go anywhere where it wants to. It could exit the foot. It could exit the chest. We don't know. So chemical burns are so critical because we have to think about the insides and our organs. It could damage the liver. It could damage who knows what. So that's why electrical burns are so critical. And chemical burns as well. When you have a chemical, obviously it could cause burning, it could cause irritation, but certain type of chemicals cause critical burns. And finally, inhalation injury. If you suspect any type of inhalation injury, you need to get the patient to a higher level of care, or begin your aggressive treatment with your airway, which I may or may not have touched on that just a couple times tonight. So I cannot stress enough, airway, airway, airway. We have airway, we have a good outcome for our patient. All right, so now let's talk about the assessment. Everything pretty much is going to stay the same. I put these next couple slides in because I want us to remember that when we classify a burn patient, we classify them under a trauma patient. So we have to remember that the burn may be a distracting injury. So these next couple slides, we're going to hit on that. So obviously we're going to start with our airway maintenance and C-spine protection. Did our patient get burned because of an explosion and landed on his neck or landed on his back? We have to keep in mind that just because this patient is burned doesn't mean that there couldn't be C-spine injury or further injury. So that's why it's so important to protect that, as well as the airway. Next, we'll kind of hit on breathing and ventilation. Is the breathing normal? Is it abnormal? What ventilation do I need to do to help our patient, if any? Circulation and cardiac status. Do they have pulses? Do we work a burn patient that's arrested? And cardiac status. What is their cardiac status prior to today? Do they have underlying issues? Excuse me. And disability. Any disabilities? And also, finally, exposure. So, airway. Like I said before, it must be assessed immediately. We have multiple options. The first one is head tilt chin lift. We learned that probably one of the first weeks of school. The next is jaw thrust. Do we have a traumatic patient? If we do, a suspected neck injury or spinal injury, then we need to be doing a jaw thrust. And finally, OPA and assessment for oral intubation. We have to remember that we have basic tools, that sometimes our basic tools are the best before we work into our advanced tools. So how about an OPA? Can we do an OPA? Can we do a NPA? And obviously, later down the road, do we need to intubate this person? Does this person have a hoarse voice? Is their face burned? Do they have soot in their oral mucosa? Do they have soot or in and around their mouth? How about in their nose? When you look into their mouth, is there redness? Is there blistering? Is there junky lung sounds? Is there rhonchi, wheezing, crackles? Is there something screaming that they need to be intubated? And those are some of the things that hopefully, if you see those, that you're thinking, okay, yes, we need to either sedate them or we need to call for further medical control as far as, hey, I'm going to intubate this guy. What can you do to try to assist me with intubating them, orders-wise? So breathing and ventilation. This is a trauma patient. We need to be making sure that the breath sounds have been checked and make sure they're equal and present. If they have a tension pneumo, we need to decompress them. Just because this patient is burned doesn't mean that we can't treat other trauma signs and symptoms. And also, let's be looking, is the adequacy of their breathing okay? Are they breathing shallow and rapid? Are they breathing deep and slow? How about, do I notice any issues with their breathing, a flail chest? And also, with a burn patient, don't be afraid. High flow O2 early, 15 liters non-rebreather mask. It's better to put the patient on oxygen and be aggressive with the airway and the breathing than fall behind. Circulation. Most likely, they're going to have an elevated blood pressure. They've been burned. They're in a lot of pain. They're in a lot of shock. They don't know what's going on. They're going to have an increased heart rate. One thing we need to think about is checking the skin around the burn site. Are they not perfusing? If they're not perfusing, then we need to try to figure out, on top of our burn care, why aren't they perfusing? Check for signs of hypoxia. Check the nail beds. Check the skin color. Check those things. Just don't stay focused on that burn. Now, this is just a number that was put out, a heart rate of 100 to 120 beats per minute in an adult burn patient. That's what they're saying. That's what the American Burn Association is saying is a normal heart rate. Obviously, that's going to differentiate. You could have it at 140, 150, and that's just what it's going to be, okay? But that's just a number that they've set out. So when burns occur, they don't bleed initially. When they bleed, that's usually more of a later down the road when they're healing. So if you arrive to find your patient after you've checked for scene safety and your PPEs are on, and you see that they're laying in a pool of blood, maybe that's an idea that maybe that's maybe a light bulb will go off saying, okay, I need to assess better because they're laying in a pool of blood. Okay, so don't get focused into just because they're burned that they're just burned. That's ultimately what I'm trying to get at with the assessment. Now, obviously, the disability, you're checking for neurodeficits, your pulse motor sensation, you're checking for gross deformities. You're either using your AVPU or your GCS, whichever one either you feel comfortable using. But just keeping all of these things in mind is ultimately going to be best for your patient. In exposure, when you're dealing with a trauma patient, and I'm sure most of us were taught, get their clothes off, cut their clothes off. We need to check for injury. And ultimately we're doing this because we're examining for major associated trauma from this event. That bomb went off or that explosion happened at work, and you have your patient who was working in that area and has third-degree burns to a majority of their body, and you're assessing them, and all of a sudden, oh, I found a piece of shrapnel in his back. That's why you're checking for associated signs of trauma. And also, we have to make sure that we're maintaining a warm environment for our patients. When patients are burned, they lose their ability to maintain their own body temperature. So wrapping them in blankets is okay. I know a lot of agencies carry burn sheets, trying obviously to keep the contamination level down, but in the long run, they're going to be receiving bouts of antibiotics. They're going to be receiving daily debridements of their wounds. So if you're not able to get that burn sheet down, it's not the end of the world. It is okay to put them on normal sheets that you carry in your ambulances and wrap them in blankets. Crank the heat. If it's 90 degrees outside, it might be 90 degrees in your ambulance, and that's okay. I remember one of my instructors told me that if you're not sweating with a legitimate trauma patient, you're not doing your job correctly. All right, so now we've talked about the airway. We've talked about the different types. We've talked about the skin. We talked about the different degrees. Now we're going to talk about the different types. So we're going to talk about thermal, chemical, and electric. So thermal. Obviously, we think of thermal. The big thing we think of is flame burns. But also, we need to think about contact burns. You grab that hot pan in the oven, or you grab that hot sandwich out of the microwave. Scalding injuries, hot water injuries. How many of us have gotten in the shower and, oh, that's way too warm? And also steam burns. Steam burns are a very common type of thermal burn that we underestimate. Chemical burns, classifications, the alkalis, the acidics, the organic compounds. I'm sure that looking at this, all of us have these items in our house. And we honestly don't think about them burning us. But in the long run, they can severely burn us. So chemical burns require immediate care. We require immediate care because we need to stop that burning process. But before we do that, we have to make sure that we're protecting ourselves. As responders, day one, scene safety. We have to keep that in mind when we're taking care of these patients. Dry chemicals, we need to be brushing them off before flushing with water. Some of the chemicals can react with water, causing the burn to be more severe. Most chemical burns can be flushed with copious amounts of water. Obviously, doing your research into the chemical is important. And finally, gathering MSDS sheets to aid in care. If you're at a company, have someone go and collect MSDS sheets for you to help you. The MSDS sheets will literally give you play-by-play of what's in there, how to take care of it in definitive care. So obviously electrical burns, we have AC/DC. Just to be clear, we're not actually talking about AC/DC. We're talking about different types of plugs and outlets that you find in your home. As the electrical burns, talking about lightning, and finally electrical currents. So AC versus DC, direct current injuries. These are from lightning strikes, and we see them in car batteries as well. So obviously here's a pretty cool picture of lightning. Now, when I saw this picture, I just imagined myself being there and just thinking how painful that truly would be, being actually struck by lightning. So keep that in mind when you take care of this patient, of the burn patients that have been caught by lightning, that they're probably going to be in some pretty severe pain. And then AC, the AC aspect of alternating current. These are going to be your refrigerators. These are going to be your household items that you're seeing, toasters, coffee pots, so on and so forth. So obviously electrical burns. Number one, coming back full circle, scene safety. When we see electrical burns, when you see them on TV or you see them in real life, they're always tensed up and they're always shaking. And that's because the electricity is literally forcing the muscle to contract. Now, most of the time we see that in the hands. So that's why they can never let go, is because they're literally tensed down. So, and the electricity is causing that. And finally, cardiac dysrhythmias. Obviously with the big one being the ventricular tachycardia and the ventricular fibrillation. Those are the two big ones that we see that have been caused by electrical burns in the patients. So finally, we're going to start moving into the treatment of our burn patients. Airway, airway, airway. I think I may or may not have mentioned this a couple times tonight. Cannot express the importance of airway management in your burn patient. Next is going to be your fluid therapy. We need to be giving these patients a lot of fluid. Lots and lots of fluid. The first 24 hours are very crucial for fluid therapy in a burn patient. And obviously pain management. We don't want our patients to be in pain. We want to relax them. If they're relaxed, it's going to be better for them. Their heart rate's not going to be increased. Their blood pressure's not going to be as high. We can better take care of them. And finally, the continuation of care. Getting them from the scene, how you're going to do it, and finally, what's going to be definitive care. So, airway, high flow O2. We need to talk about oral intubation. That always needs to be in the back of your mind. How I kind of hit on it earlier with the signs and symptoms. Always have that in the back of your mind. And finally, in our all-ditch effort, needle crike. Needle or surgical crike is another option that you can use. So here, I kind of jumped ahead a little bit, but here are some of the indications for early intubation. Hoarseness or blackened sputum, stridor, total body surface area of burn is greater than 40 to 50%. Extensive facial burns, burns inside the mouth, change in voice, and finally accessory muscle usage. These people are working hard, and that's primarily because their airway is closing around them due to all of that inflammation caused by that burn. So ultimately, this this individual is severely burned. We can classify him as a critical burn. And ultimately, I don't know the story behind the actual picture, but it looks like they're kind of on the right track with taking care of the patient. They have intubation in place, and ultimately, they're waiting for the airway to begin to heal on its own. And this individual probably will remain intubated for quite some time until they're able to safely take that tube out. When we look at the picture, we can see the second degree type 2 burn. His lips look very swollen. It looks like there's some blackened in the mouth. So obviously we would classify this individual as a critically burned patient. So the needle crike, obviously this is a total airway obstruction. The airway is closed off. They've stopped breathing. So this is our last ditch effort. This is the last thing that we could possibly do in the pre-hospital setting before we get to the hospital, to where they have more technology, they have more training, they have more education on this. But once again, when you're on scene of that burn patient, always keep that in the back of your mind so you're ready to go in case if you're actually having to do that. So now we go to the rule of nines. This is how we calculate the severity of the burn. We need to remember that when we're doing the rule of nines, we're only using this for partial or full thickness burns. We're not doing this for your first degree burns. It's going to be your second degree 1 and 2 and your third degree burns. Remember that there is a major difference in adult and children. And primarily, it's going to be the head. The size of the head for the children is a lot larger. The surface area is a lot larger than an adult. And ultimately, we're using the rule of nines for fluid resuscitation, which we will talk here in a few minutes, or right now. Fluid therapy. Most of us use the Parkland formula. And ultimately, we're using the fluid therapy to support tissue perfusion and organ function. That is our main goal. Once again, you're only going to be using this on second and third degree burns. We're not going to be spiking a bag for a first degree burn patient. It's very critical that we do use excessive amounts of fluid in the first 24 hours. Burns 20 to 25%. You have an increased capillary permeability in intravascular volume deficits. These are kind of some formulas that were sent out by the American Burn Association with adult thermal and chemical burns. We also have here for the pediatric level. And then obviously with high voltage injuries or electrical burns, like I said before, we don't know the extent of the injury. So we're obviously going to want to give more fluid. One of the big things that you may be able to tell if there actually is extensive damage is that there actually are red pigments in the urine. And this is because of the deep tissue injury caused by that electrical current going through the body. With your pediatric patients, you're going to want to contact your burn center. That's what the American Burn Association recommended that you do for guidance with the Parkland formula, just because you're going to want to give that little extra fluid, but not too much. Ultimately, we're going to want to be giving up to a liter prior to arrival at the hospital, if not more. Obviously, we're going to want to keep it around the 250 normal saline bolus. But there's been more research with lactated ringers being better for burn patients, and that ultimately breaks it down to the cellular level. And that's why for lactated ringers being better in definitive care. But as far as a pre-hospital treatment, normal saline still is okay to be giving. Obviously, different agencies throughout the state carry different types of pain medicine. The most common ones are obviously going to be fentanyl, morphine. These are going to be for your more severe burns. For your first degree burns, for comfort care, maybe just a cool wet dressing around that wound, or around that burn site to make them feel a little bit better. So ultimately, kind of going throughout this whole entire thing and hopefully taking away, what maybe thinking to yourselves, where is our regional burn center? Because a lot of times we don't take care of a lot of burn patients. It's not a very common call that we run in the pre-hospital setting. And then also in the future, kind of talking, what type of patients would we transport to the burn center? Keeping that in mind. And finally, in protecting yourself, scene safety, scene safety, scene safety. I can't express it enough, maybe almost as much as airway. And then finally, make sure that you're gaining a complete history. This is going to be helpful for the hospital. It's going to be helpful for you. Kind of discussing decreased blood flow to certain areas, medications. Are they on blood thinners? What kind of history have they had before? Do they have skin problems to begin with? Those kind of things. Just make sure you're gaining a complete history. Pediatric and special considerations. Pediatrics, we have to make sure that when we go to these burn patients that we're looking for things that don't really add up, maybe leading to you thinking of an abuse or neglect case. And also with infants and children, remember that they have a larger body surface area, which can have increased effects. Ultimately, with your fluid management, with your pain management in definitive care. And finally, pregnant burn patients. With pregnant burn patients, you have to keep in mind that, yes, they're burned, but also you also have a baby growing and developing inside as well. So there hasn't been much links to issues with pregnant burn patients, but always keep that in mind. But in the long run, the definitive care and the pre-hospital care isn't really going to change as far as pain management as well as fluid therapy. So I just wanted to thank you for this opportunity. I hope that someone has learned something new today, and hopefully this was a nice refresher for something that we don't really do on a daily basis. So thank you for your time, and I think now we'll open it up if anyone has any questions or comments. So yeah.
Thank you, Andrew. That was a phenomenal webinar presentation. You did a great job. At this time, I will go ahead and unmute all the lines. If anybody has any questions or comments for Andrew or myself, you may go ahead and speak up.
Any questions? Nope.
I would also allow anybody that joined in late by audio or even by the Zoom software and you weren't able to give me your first and last name for attendance purposes, you can go ahead and say your first and last name for me as well.
Okay. Linda Ryala.
Thank you, Linda. I do have you down as in attendance.
Thank you.
You're welcome. And again, if anybody has any questions for Andrew at this time, please speak up.
They can hear us right now. They can hear you right now. Can you hear me right now through speaker?
Yes.
Yep, I can hear you. Andrew, can you hear it?
Yep, I can.
All right, go ahead, sir.
More of a comment than anything else. I wish you would have shown more burn patients on here instead of so many dialogue on the slideshow. I would like to see third degree, second degree, more of them anyway.
Okay, I will definitely keep that in mind for future. I appreciate that. Thank you.
That was a great job. Thank you. Oh, I'm sorry. Go ahead.
On second and third degree burns, are hospitals using dry or wet bandages now, dressing? I know it's changed in certain hospitals, certain things, but what's the common dressing used now?
The common dressing is dry dressings, kind of across for the second and third degree burns, and then for the first, they're still kind of keeping with the cool moistened dressings.
Perfect. Thank you.
Yes.
Got another comment. Can you still hear me?
Yes, I can.
Okay. Hi. This is Ken. When you were talking airway, I understood all you say, airway, all the way. It would be nice to see a burned or crushable airway.
I'm sorry, you broke out. I didn't catch the last part.
Yeah, for your comment section here, you preach and teach airway, and I understand full well what you're getting. What I'd like to see is more pictures on your slideshow of compromised burned airways.
Okay. Yeah, definitely. I'll keep that in mind, and that actually makes a lot of sense because, we can just preach it all day, but I mean, who knows what you're looking at, you know what I mean? So that's great. Thank you.
Yeah, your slideshow, it's okay. I'd like to see just more pictures all the way around, more graphic pictures.
Okay. Yeah, I will write that down and keep that in mind. Thank you.
Andrew, this is Kathy from Roscommon. We think you did a great job with less than an hour of education. You put a lot in here. It was all encompassing, and we thank you very, very much on behalf of me and my several employees who are here.
Thank you. Thank you very much. I appreciate that.
Does anybody else have any comments or questions for Andrew at this time?
Good job, thanks.
Thank you.
All right. Well, just to remind everybody, you do have until Monday, March 28th, 2016, to fill out an evaluation, a quiz, and attendance form in order to receive your 1 credit of continuing education credit. And again, for those of you that did attend the February webinar and are still waiting on your continuing ed credit sheet, you should be receiving those if you haven't already. Again, my administrative assistants who normally send those out were out of the office last week, so they will be catching up and finishing up that process this week. And again, I did record this webinar along with the February webinar, and those will be posted to the Michigan Center for Rural Health website, and I will provide that link to you in the email that I send out once the webinar has concluded. And if there's no other questions or comments at this time, thank you again for participating in tonight's webinar. And thanks, Andrew. Thank you for taking the time and effort into presenting. You did a great job.
Thank you. Thanks for the opportunity.
Thank you, Andrew. And everybody, I hope you have a great night, and hopefully wherever you are, the weather is pretty good. It's pretty good here in East Lansing. It's about 50 degrees and kind of gloomy, but spring is on its way. And at this time, I will let everybody go, and I hope everybody has a great night and expect an email from me shortly. Thank you.
Thanks, Emma.
Thank you.